it is my great pleasure to introduce Dr. Kerry Schaffer, who is a medical oncologist based at the Vanderbilt University Medical Center, Vanderbilt Ingram Cancer Center. And Kerry joined us a couple of years ago as faculty. We're really excited to have her here. She graduated from the University of Virginia School of Medicine and completed her residency and fellowship in hematology oncology at the University of Rochester Medical Center. She's board certified in internal medicine and medical oncology, and currently, like I already said, is a faculty member at Vanderbilt. And she focuses on urological cancers, and she's had a pretty long-standing interest which started, I think, during her fellowship in inherited cancers. So again, I'm really excited to hear what Kerry has to say, and I'll let her take over. And this is one of the first ones where Kerry has taped her presentation, but Kerry is here and she will be addressing questions once the presentation is done.
Hi, my name is Kerry Schaffer. I'm an assistant professor at Vanderbilt University Medical Center, Ingram Cancer Center, and I'm very happy to participate in this ICARE conference today focusing on germline mutations in prostate cancer. In this talk, I'm going to review background data on germline DNA repair mutations and their role in prostate cancer, and then go through data from clinical trials that has led to the FDA approval of numerous PARP inhibitors, highlighting what data is the most convincing for therapeutic benefit and looking to see where else we might use PARP inhibitors in the future. I'm then going to briefly summarize the current germline testing indications for prostate cancer, and I also look forward to talking through the case studies today. When treating patients with prostate cancer, it's very easy to recognize that there's a high degree of variability in clinical presentation. For patients with advanced disease, there are those patients that have really indolent disease, some of who can get treatment for many years, and there's also, unfortunately, patients with very aggressive disease who have a prognosis less than a year. As with most cancer types, there's large efforts to try to better understand genetic drivers of prostate cancer. And with more knowledge about genetic and genomic features in prostate cancer, there has been in the past few years numerous PARP inhibitors approved for prostate cancer precision therapy. These show great promise for exploiting genetic and genomic vulnerabilities, and more trials are ongoing at present. One of the first key publications in this area was by Robinson et al. In 2015. This research conducted whole exome and transcriptome sequencing of tumor biopsies from a cohort of 150 patients with metastatic castrate-resistant prostate cancer, reporting on frequencies of both somatic and germline aberrations. There was 12.7% of cases with loss of BRCA2, 90% of these were biallelic, and 5.3% of these represented a germline BRCA2 mutation with a subsequent somatic event. When looking at a broader gene panel, this study found that almost 20% of patients with metastatic castrate-resistant prostate cancer had biallelic inactivation of DNA repair genes, and about 8% of these represented a germline mutation. So the take-home from this study was that about 1 in 12 patients with metastatic castrate-resistant prostate cancer had an inherited cancer predisposition in BRCA1, 2, or ATM. The study by Robinson et al. Was followed closely by work published from Pritchard et al. In 2016. The study reported the frequency of DNA-repaired germline mutations across 3 different populations. This was 692 patients with metastatic prostate cancer, 499 patients with localized prostate cancer, and over 53,000 patients with adenoma cancer. This table highlights the 20 genes that were tested in Pritchard's study. You can see it covers a wide panel of germline genes related to DNA repair processes, including homologous recombination and mismatch repair. A total of 84 germline DNA repair mutations were identified in 82 men, so this is a rate of 11.8%. There was indeed a higher proportion of patients with germline mutations in advanced disease compared to local disease or no known cancer. This highlighted that approximately 1 in 9 patients with metastatic prostate cancer have a pathogenic germline mutation in DNA repair. Genes that were found to have significant difference in mutation frequency compared to the general population or localized prostate cancer population are highlighted in the box here. The most commonly identified germline mutation in metastatic prostate cancer was BRCA2. This was followed by ATM, CHEK2, and then BRCA1, which is only about 1%. The diagram on the right here shows the process of homologous recombination. This is a mechanism for double-stranded DNA break repair. And you can identify that germline alterations most commonly altered in metastatic prostate cancer are involved in this DNA repair pathway. So this sets the stage for exploring the potential for PARP inhibitor therapy in metastatic prostate cancer. In the interest of time, I'm not going to go through all of the PARP inhibitor studies that have been done in advanced prostate cancer, but I hope to highlight trends that are identified about responses to PARP inhibitor for numerous studies. In most of the PARP inhibitor trials in prostate cancer, the genes were broken up into two arms, one with BRCA1, 2, and ATM, and a second with all the remaining genes. So Triton-2 was an open-label phase 2 study that evaluated safety and efficacy of rucaparib in men with advanced prostate cancer. All of these men had had at least one hormonal therapy and also were exposed to a taxane chemotherapy, so heavily treated patients. The patients were screened for DNA repair defects and were considered eligible if they'd had progression on prior therapy and also did have a DNA repair defects. The list of DNA repair genes are listed here. And rucaparib was administered until confirmed radiographic disease progression, toxicity, or death. This table shows the response rate to rucaparib treatment in the overall study in patients with measurable disease at baseline. 43% had confirmed radiographic response. Mostly these were partial responses, and 45% of patients had stable disease. In the total study population, 54% had confirmed PSA response. This table highlights the larger number of BRCA2 patients in the trial and also the difference in overall response rate by BRCA gene, with stronger data in the BRCA2 patients, both by number of patients enrolled and the actual radiographic response rates. Among patients who did demonstrate confirmed radiographic response, the majority of patients, over 50%, had a response that was lasting longer than 24 weeks. Among patients with a BRCA1 or 2 alteration, 52% had a confirmed PSA response. Responses to rucaparib was observed in both germline and somatic alterations. These are seen as yellow and green boxes at the bottom of the graph. There was also a fair response rate, and you can see by gene, the last column here, these other gene alterations did have a fair PSA response. These included PALB2, BRIP1, FANK-A, and RAD51, but these were all very small in number and had to be collected as a group for a total of 14 patients. Finally, a limited number of radiographic and PSA responses were seen in patients with ATM, CDK12, and CHEK2 alterations. So this data suggests that there's non-BRCA biomarkers that are associated with PARP inhibitor activity in metastatic castrate-resistant prostate cancer, but more investigation is needed. Ultimately, this Triton-2 trial did lead to the approval of rucaparib for advanced prostate cancer, but only for BRCA1 and BRCA2 alterations. The PROfound trial was a randomized phase 3 trial that looked at radiographic progression-free survival, overall response rates, and overall survival. This study looked at olaparib versus novel hormonal agent, and patients were randomized 2-to-1. It's important to note that this trial did not require chemotherapy exposure in the castrate-resistant setting, and also they did allow for crossover, and about 80% of patients had crossover from the control arm. Looking at radiographic progression-free survival, BRCA2 did have significant improvement. In the overall study population, the median imaging progression-free survival was significantly longer in the olaparib arm. It is 5.8 months compared to 3.5, statistically significant, though not a tremendous duration. That being said, for advanced prostate cancer, these can be meaningful amounts of time for patients. When you look at the individual gene breakdown, there was a lot of variation in the specific genes. Again, the ATM cohort did not really show the same magnitude of impact between the control arm and the olaparib arm. You can also take note that the numbers were very small from BRCA1 mutations, CHEK2 mutations, and RAD51 in the order of 8 patients in the treatment arm, 7 and 4 and 3 for the RAD51 and 54 proteins. Looking at the overall survival analysis, for the arm A, you do see a significant overall survival benefit for patients that were treated with olaparib, and keeping in mind this did allow for crossover. 80% of patients in the control arm did crossover. When looking at the entire study, there was a trend towards overall significance, but it was not statistically significant. So just to summarize, results from the Triton-2 study were published in early 2020 and led to the first FDA approval for prostate cancer PARP inhibitors in May 2020 under accelerated approval. Continued approval for this indication is contingent on the Triton-3 trial, which is a randomized phase 3 trial. Again, to emphasize, this recap of approval is for BRCA1 and 2 gene alterations following taxane chemotherapy. For olaparib, the approval came after the PROfound study was reported, and it did get approval for all genes that were studied, aside from the PPP2R2A gene, and does not have any specifications regarding chemotherapy. The PROfound trial also led to the approval of olaparib for BRCA1 and 2 alterations after review by the EMA, but it was designated only for BRCA1 and 2 gene alterations based on the overall survival benefit noted in cohort A. So now we have 2 FDA-approved PARP inhibitors with some overlap in their indications, and the question is, how do we apply this into clinical practice? I'll comment that this slide does not reflect any formal guidelines, but it's just more of an informal opinion about the strength of the data we have thus far from these trials, as well as other PARP inhibitor trials that I did not go through in detail. I think that for patients with BRCA2 alterations, either germline or somatic, which fortunately is the most common alteration in metastatic prostate cancer, the data clearly does support integration of PARP inhibitor into the treatment approach. Also, I feel that BRCA1 alterations do show data to suggest benefit, and hopefully as more data is collected over time in larger numbers through trials, this benefit can be confirmed. What's more challenging is when thinking about other individual mutations, the numbers are really small, and some genes, the response rates were discouraging. Genes that look promising might include PALB2, RAD54, RAD51, but ideally we're going to have to get more data on these patients through clinical trials to really clarify its benefit. The ATM subset and CDK12 do not have a consistent impact on progression-free survival and response rates. And so the question remains, do we need a different tactic to use for that type of precision therapy, a different mechanism for our therapies? Ideally, for the FDA approvals we have here, I think it's clear that for BRCA2 mutations and BRCA1 mutations, we do have successful therapy options with PARP inhibitor. It's really important, though, that we continue to enroll patients in clinical trials and really try to parse out what and how patients can get true benefit from precision therapies in prostate cancer. Just as we've seen with breast and ovarian cancer, there's new trials now looking to see if PARP inhibitor earlier in treatment or in combinations might provide patients benefit. So there's patients that are now enrolling on trials with metastatic hormone-sensitive prostate cancer. There's trials going on in advanced metastatic castrate-resistant prostate cancer with new single agents or PARP inhibitors in combination. There's also PARP inhibitor trials going on in the perioperative setting for localized disease. So it's very exciting to see these trials ongoing, and it'll be interesting to see in the coming year and years where PARP inhibitors are used and where they have the absolute most benefit for patients. So in sum, there's a large role that both germline and somatic testing play in managing prostate cancer. There's important treatment implications for patients, and it can also provide more benefit to patients when they pursue cascade testing. If patients have awareness of a hereditary cancer condition, it opens up opportunities for their family members, and this increased testing in family members of patients can ideally help to lead to early detection and prevention for patients with prostate cancer as well as other types of cancers, and therefore improved outcomes for these patients as well. I'd imagine that most of the audience here is aware, but current NCCN guidelines recommend somatic NGS and offering germline testing for all patients with metastatic prostate cancer. All patients with high risk or very high risk disease, as well as those with cribriform or intraductal disease, also qualify for germline genetic testing. I've had a fair number of patients and also providers ask what is cribriform or intraductal, and this is simply just a histologic subtype describing the architecture of the tissue under the microscope. Up top there is an example of cribriform histology, and below is an example of intraductal. In addition to the histology features outlined on the last slide, there's also familial history as well as personal history that can qualify patients for germline testing. These are outlined here, and then there's also the suggested gene panel outlined in the blue box. A lot of testing companies do have a broader panel that can be used, but these are the recommended genes for prostate cancer specific testing. This slide summarizes the national recommendations from NCCN as well as the Philadelphia Prostate Cancer Consensus Conference and other organizations nationally. on what to do for males with a known hereditary cancer predisposition syndrome and no diagnosis of prostate cancer. General principle is that in men with a family history of prostate cancer, men of African ancestry, and those with a known high-risk germline mutation and no prostate cancer, they can start screening earlier at the age of 40 as compared to 45 in the average risk population. There's a clear recommendation for BRCA2 and a less strong statement that it can be considered in BRCA1, ATM, and mismatch repair, as well as HOXB13. The stronger recommendation for BRCA2 is based on data from the IMPACT study as well as others about more aggressive disease, higher Gleason score, higher risk of occurrence for BRCA2 mutations in localized prostate cancer. When patients are getting their PSA checked, if their PSA is greater than 3 or if the patient has an abnormal digital rectal exam, many urology practices are now incorporating MRI into the workup, and this precedes the biopsy. MRI can increase sensitivity for clinically significant prostate cancer when compared to transrectal ultrasound biopsy. And for the general population, MRI use is supported prior to biopsy, but not really as part of the screening. There's recent trials that look at using PSA and MRI as screening tools for males with known BRCA mutations. And I think that MRI in prostate cancer screening for this population is still evolving, but it's likely going to be incorporated into the diagnostic process on a wider scale over time. I think for patients with a known hereditary cancer predisposition syndrome for prostate cancer, having them engage with a urologist with a specific focus or interest in this high-risk population is really smart. Might open up opportunities for research and also registries, which will only inform the outcomes on a wider scale for patients and hopefully benefit that patient as well. I hope that talk was informative to you, and I really appreciate being asked to speak today. I look forward to talking through the cases, and I'm happy to take any questions.